Well, we're all looking forward to going to Seoul, and we're looking forward to this great panel discussion that we're going to have today. The focus of this morning's plenary is leveraging co-production during the COVID-19 crisis. And we have with us today 4 people from different parts of the world. Anna Edwards from England, Amith Shetty from Australia, Christian von Plessen from Switzerland, and Eyal Zimlachman from Israel. You'll see that they've had different roles and responsibilities and very creative and effective responses to COVID. And we'll get started with me just providing a very brief context about co-production in health and healthcare. Co-production is a term that Elinor Ostrom, the Nobel laureate, popularized. And she won a Nobel Prize in 2009 for showing that her research proved that under some conditions, co-production was a more effective way of managing well common pool shared resources like fisheries, like pasture land, like sanitation systems, and perhaps like healthcare systems. We believe like healthcare systems. So this is a relatively new idea that's been gaining momentum since about 1980. It's moving throughout the world, and it's moving into science. This is the journal Nature, perhaps the leading scientific journal. And in 2018, they had a special issue on co-production. Co-production of research and power to the people. It reads, everyone gains when researchers partner with the public and policymakers. The knowledge generated is more likely to be useful to society and should be encouraged. Co-production is better for society. It also leads to better research. So this is really starting to move through society. What is meant by co-production? Well, Dr. Paul Batalden, a leader in quality internationally, provides us a definition. So co-production in healthcare, the interdependent work of patients and professionals to design, deliver, assess, and improve the relationships and actions that contribute to the health of individuals and populations through mutual respect and partnership that leverages each participant's unique assets, expertise, and actions. So that's a formal definition, and I think what you'll see in our brief presentations, how this comes to life in responding to the COVID-19 crisis. So Anna, you're going to lead off.
Thank you, Jean. And I'm not sure how I'm going to get on in South Korea because I'm still working with paper and notes. So I'm going to have to up my game for next year. So my name is Anna Edwards. I'm from England, as Jean said. This is a bit about me, but I'm not going to talk about that too much. I'm a barrister by background. I'm currently working in the NHS as the head of the National Staff Retention Programme. And I ended up changing careers because of my own journey as a patient. I changed careers about 12 years ago. And unfortunately, I've been a patient for around 25 years. So I'm going to talk today a little bit about my personal journey and then talk about how that felt during the COVID-19 pandemic. So this isn't a year, it's not 1942, it's my life between the ages of 19 and 42. So I was diagnosed with Crohn's disease back in 1996. And at the time, I was told by my doctors that it would be a mild inconvenience. 25 years or so later, I've had over 30 major bowel surgeries. I've had stomas, temporary stomas. They've been reversed. I now have a permanent stoma, but frankly, it's saved my life. Sadly, I've suffered sepsis more than once. I've had pneumonia. I have ongoing anemia and osteoporosis. And about 5 years ago, I had IVF and realised that I was also suffering with infertility. But sadly, the IVF drugs caused my ureters to block, both my kidneys failed, and I was put into a life-threatening situation. That's not the only near-death experience I've had with my illness. So I think it's fair to say a mild inconvenience probably doesn't quite cut it, actually. But there you go. So just as I was getting my life back, and I did get my life back due to the wonderful medical team at Guy's and St Thomas's, who I want to thank today, because I wouldn't be here without them. Just as I was getting my life back, the pandemic hit. And when I was asked to speak today, I thought hard about how to kind of present my thoughts in a coherent way, and spoke to lots of other people with chronic illness about, what to say. And many of you will have heard of the Kubler-Ross 5 stages of grief, that theory that's very well known. And so I decided to develop the 5 stages of COVID-19 for a person like me with chronic illness. Now, I think it's fair to say that the vast majority of people in our global society felt fear at some point during the pandemic. And so there's my fear line across the top. However, for those with chronic illness, this fear was, and if I'm honest, continues to be, an ongoing continuum. But the first stage underneath that fear was, for me, withdrawal. So we know in 2020 that the world changed, and now, of course, it feels like we've got many of the answers. But at the start, no one had the answers, did they? We knew people were dying. We quickly knew that some were more vulnerable than others. And there was no doubt that those who were immunocompromised were at very high risk. So many patients who felt vulnerable withdrew from healthcare and society. Many were scared to go out. They were scared to access the healthcare system, and that might have been because of fears of contracting the virus, or because they knew of the pressure on services, and certainly that's how it felt in England, where I'm from. Many more had their patient voice taken away as health systems went into crisis mode. Systems that were often focusing on what was perceived as essential at the expense of the nice to have, e.g. co-producing outcomes, enabling patients to have advocates beside them when at their most vulnerable. I was no different, but my withdrawal was perpetuated by policy and rules. Now, the vaccine was a game changer, but of course it wasn't available to all of us immediately. There were strict criteria in place, and I'm sure it was the same in the countries that you're from. And despite having a very complex medical history, which I've explained to you already, I wasn't immunocompromised. I was no longer taking any drugs. So I had to wait until they were vaccinating healthy 40-year-olds, people with no medical history at all, before I could be vaccinated. And that was terrifying. I begged my GP to review this, but we'd gone back to a policy says attitude rather than what was right for the individual patient. I knew then, very early on, that I'd lost my patient voice. And so I withdrew, as I thought, after 25 years of battling Crohn's disease, I was now going to contract COVID-19 and die. That withdrawal continued when I did receive the vaccine, as I had what felt like a severe reaction to it. And it took me back psychologically to when I'd had sepsis. They were the same symptoms. And I knew the vaccine was new, and I knew that hospitals were full. And I just thought, am I going to end up being admitted now to hospital due to the vaccine? I was really frightened of what might happen. And to be honest, that withdrawal stage lasted for many months. And for a significant amount of time, all of us withdrew as our options to go out were limited by government-imposed lockdowns. However, for those of us with illnesses, when everyone else started to breathe a sigh of relief and return to society, we remained at home, scared to invite anyone in or let anyone in our family out. However, as the number of people dying from COVID started to drop, the withdrawal phase, for me and many others like me, moved into one of inquisitiveness. What does this pandemic mean for me? Could things actually be better as a result? Could I have telephone appointments in the future rather than having an all-day round trip to the hospital? And that was quite a short stage before people with chronic illnesses started to move into a stage of strength. As I said earlier, my quality of life had been severely impacted by Crohn's disease, and just as I was getting back on track, COVID-19 hit. Post-vaccine, I wanted to be strong. I wanted to get out into society, to talk to my doctors about how the year before had been, and understand from their perspective why so much had gone out of the window in terms of co-production. I travelled again, and I spoke with others who had long-term conditions and encouraged them to get out and enjoy life again. The fear was still there, but for many patients, they just needed a conversation with their doctor to understand their specific risks. And do you know what? The health system needed us too. They needed to learn from our experiences. Who continued to be at risk? Who was contracting the virus still? How was it affecting people with different conditions? So co-production and patient power started to re-emerge. And then came excitement. Excitement about the future. Improvements had been made, and we, the patients, might actually get to benefit from those. So I can now get a blood test at my local hospital because I can't go to the GP. Sadly, there have been so many cannulas in my arms that they don't work anymore. So I have to go to the hospital. But now I can do that using a 5-minute appointment system. I'm in and out before I need to pay for parking, which is a fantastic bonus, and I'm at work by 9 a.m. Before, I would have been waiting hours in a queue for something that took 2 minutes to do. I now have an outpatient's appointment on the phone. No more cost or time taken to travel to the hospital on top of long outpatient queues. When I contact my GP, I don't have to wait for long periods to speak to the receptionist. I now have an online booking system where you're triaged and you'll receive a text, a phone call, or a face-to-face appointment. And I can book this from anywhere in the world and upload photos if I want to. These changes give people their lives back and enable patients to be more in control of their illness. And so we move to the stage of innovation and greater co-production. We've seen how the system can change and the benefits to patients as a result. And sadly, it did take a pandemic to do this at pace. But we can build on the things we've developed and improve them again. E-consultations could be expanded where suitable for the patient. Telephone appointments could routinely become video appointments to promote the doctor-patient trust dynamic. The bottom line is COVID has taught us that innovations and efficiencies are out there, but the real bonus that if done well and produced in collaboration with the patient, these can benefit the system and the user in equal measure. But there are still some post-pandemic risks for co-production. Even though there's a really positive story, I think these are the areas we need to look out for. We know in many countries there are elective backlogs. Staff are operating at pace, and they have limited time or capacity to co-produce outcomes with patients. Our workforce is struggling. We're trying to recruit and retain staff in our health systems, but it's a challenge. And we know, having listened to our employees in the health systems in which we work and through the sessions in this conference, that staff are feeling burnt out, demotivated, some are suffering with PTSD, and with less staff comes less time for patient voice. And there's a risk we return to paternalistic behaviours just to get that growing number of patients through the door in what are increasingly understaffed facilities. We have financial constraints in many parts of the world and certainly in the NHS. And that's as the world economy struggles to bounce back from the effects of the pandemic. And that might lead to rationing of services and less emphasis on patient-focused roles in our health system. For instance, advocates, health systems that end up going back to basics and start focusing on delivery of healthcare at any cost. And then we have a failure to learn. During the pandemic, we saw far too many people withdraw from health systems and thereafter find themselves sicker due to symptoms they didn't want to trouble the health system with. We saw too many people die alone as care facilities stopped relatives and carers from visiting their loved ones. In many places, we did see a return to paternalistic healthcare fueled by crisis management approaches, which too quickly threw out of the window essential elements, including co-production. And now we're seeing perhaps a reliance on some of the new ways of healthcare delivery. For instance, remote appointments, but that is not learning and understanding sometimes what is best for the patient. That's replacing for the sake of convenience. What if the patient needs to be examined, for instance? So whilst many of these initiatives are great, and I've said how wonderful they are and how much they've changed my life, it's important that we speak to the patient and understand what matters to them, so that care can be delivered in line with their needs and not just in line with the health system they are accessing. So finally, my challenge to you. Really, I'd like you to think about what innovations have you seen as a result of COVID-19 that have directly benefited patients? Were they designed with patients or simply as a direct result of the crisis? Do they continue to benefit patients post-pandemic? How do you know that? Have you asked the question? And what innovations can you go back and assess to understand the real benefits to patients in the medium to long term? How can you involve patients in improving these so that they work for individuals as well as the system? Now, in the first two rows here, I've put some letters underneath your seats. I'd like you to take them out now, but please don't put them up. We're going to come back to that. But I want to thank you today for listening to me, and thank you to ISQua, who have accepted me as one of the honorary advisors to their board on person-centred care. It's a real privilege to do, and it's a privilege to be with you all today. Thank you very much.